everyone. My name is Jason Pang, and I am a laser dentist that practices in Neutral Bay in Sydney. I've got a special interest in doing anything with the laser, which is quite a lot nowadays, and we won't really sort of get to talk a lot about that, but certainly there's many more things than just the conventional drill that, in dentistry nowadays. And I'll show you some of the things that we do, but it's pretty exciting. So today I'm going to talk about really the oral systemic connection and how I think the oral biofilms and live microscopy fit in with that. It's become an important part of my practice, and I've been doing it since May. And there's so many surprising things that I've seen in just that short amount of time. And I'd like to share because there's very much a crossover between the dental community and the medical community. So let's get started. So this is a very traditional view of dentists where the type of people that involved with pulling out teeth that try and make the teeth straight and make them look good, make them look beautiful. But ultimately, we still stick a lot of things in the mouth, and that is something that a lot of patients don't like. But we are moving away from that, and definitely we still do a lot of fillings. Now this is a dental laser being used to do a cavity, and the nice thing about using dental laser is that we don't need to anesthetize the patient. The laser doesn't even touch the patient, and so very comfortably we can prepare a tooth like that. But at the same time, we're also treating things like trigeminal neuralgia, burning mouth syndrome, facial pain, things that typically don't have very good outcomes. Other things like fibromyalgia, cold sores, ulcers, even joint pain, any sort of pain in the face, orthodontic pain, and so on. And then we have oral mucositis, which is one of the side effects of cancer therapy and chemotherapy. And internationally, photobiomodulation is actually the way to treat oral mucositis, because it helps those lesions to heal up more quickly so that you don't have repeated ulcers, building on top of ulcers. You don't have that fibrotic lesion happening and causing scar tissue and so on. We can also do things like this, which is wound healing. So this little girl, she had an accident. She knocked out her two front teeth. Luckily, they were baby teeth. And over a period of 8 days, we saw her 4 times use the laser and treated that. And you can see by day 8, it almost looks like she hasn't had anything done. This is a case of facial palsy, and the patient came in. He had a viral infection, herpes zoster, which affected his facial nerve. So he wasn't able to move the right-hand side of his face, couldn't close his eyes, so on. Very traumatic for him because he worked in an industry where he was face-to-face with a lot of people. But you can see after 6 weeks, we made quite a considerable amount of progress for him. And it did take a number of months to get full recovery, but this is the kind of thing that we're starting to do. We're moving away from that architect, engineer type approach in dentistry and more towards the being an oral healer. So these are some extreme photos of dental caries. So, but it is still the most common non-communicable disease worldwide, as defined by the World Health Organization, leading to tooth decay, pain, infection, and so on. And periodontal disease, which we think affect about 10% of the worldwide population, but again, in severe cases leads to tooth movement and gum recession, bone loss, and eventually tooth loss as well. But considering that we are a first world nation, or we consider ourselves to be, let's see how we're doing. Well, unfortunately, this is some statistics coming out of Victoria, but nearly 50% of 5-year-old kids have some sign of tooth decay. And over 51% of 55 to 74-year-olds there have got gum disease. And we're finding that, we have, some 10 to 14 type of oral cancers that we pick up each and every week. So as a first world nation, I think that there's a lot of room to improve. Certainly diet, it can be improved. Cleaning can be improved, but these are all resources that for us as a reasonably well-developed socioeconomic country, we should be able to deal with. So why do we have some of these problems? Well, it is, first of all, a bacterial infection. So in the mouth, we have many types of bacteria, and I'll show you some different types, but they're the ones that cause caries, and there's one that cause periodontal disease. We need to have something that the bacteria can act on, so that in the tooth complex, in the case of caries, yes, the tooth may have more caries if the tooth is defective in some way, and maybe there'll be less caries if the tooth has been highly fluoridated. But the type of patients that come to a dental surgery, typically they are the type that are brushing with fluoridated toothpaste every day. And then in the case of periodontal disease, you have the pockets that are affected. And when the bacteria go in there, they can start to affect the bone, affect the gum, and that's where the bone and gum can shrink away. We know that food is an important part for the bacteria, and if we feed them things that they like the sugars and simple carbohydrates, then they're going to make acid more effectively, reduce the pH in the mouth, and then essentially dissolve the teeth. But in the case of periodontal disease, there is no special diet. They like all the things that we like, and they can very effectively utilize that to grow it and replicate. Of course, we need everything that's in the mouth to stay there for a certain amount of time before we can start to have an effect on the teeth. But in the case of home care, home oral hygiene, most people would be expected to brush in the morning and at night. And that's a fairly typical scenario. And for a lot of people, that is sufficient. And in the professional realm, we would typically see the patients every 3 to 6 months, depending on their condition. But again, that professional clean is what removes a lot of that calculus, the buildup. But as you will find out, other things as well. And then when we look at some of the protective mechanisms that the body has, the saliva has a lot of protective enzymes, lactoferrin, lysozymes, but that's where the immune system is also combating some of this bacteria. And so this is where you can have some genetic differences. I've seen where different members of the same family with the same diet can have completely different presentations of decay in their mouth. And the other thing as well is that it's a time-based thing. So the immune system is not as effective as we get older. The term immunosenescence, and that is why we have periodontal disease increasing as we age. In Australia, the average is about 30% of the population. But as we know with COVID, it affects the elderly more than the young. So if we look at what's happening in the mouth, see that quote there, it says the mouth houses the second most diverse microbial community in the body, harboring over 700 species of bacteria that colonize the hard surfaces of the teeth and the soft tissues of the oral mucosa. And just remember that it's not just the teeth, but it is also the soft tissues. We'll come back to that a little bit later. But this is well recognized, even in 2016, where this quote came from. But you can see many different types of bacteria. And the thing about the bacteria is that there are some that are in the body that are very good for us, that will help with, for instance, digestion of food, the commensal bacteria. And then we have other bacteria which are opportunistic or pathogenic. And so that includes the bacteria, viruses, parasites, and so on. In about 1998, we realized that there are actually 11 types of bacteria that are actually pathogenic, and we've called it various complexes, red complex, orange complex, and so on, to try and help us remember some of the bad ones. You might have heard things like AA, P. gingivalis, and so on. But in the mouth, they would typically, in more than 80% of cases, exist as a biofilm. Right? So let's see, what is a biofilm? So let's look at this video.
Once tooth enamel is cleaned, salivary glycoproteins quickly deposit on the tooth surface, allowing pioneer species of fast-growing bacteria in the saliva to bind, recolonize, and quickly begin reforming the biofilm. Then other species attach and continue developing a thicker biofilm. The bacteria multiply, producing polymers, and even communicate with each other, resulting in a complex three-dimensional biofilm. The early colonizers are beneficial, good bacteria. However, they can create an environment for slower-growing, pathogenic, bad bacteria to start to thrive. Inadequate oral hygiene allows for a thicker, more mature, and complex pathogenic biofilm to develop, which can lead to an imbalance between the good and bad bacteria in the oral microbiome, a term called dysbiosis. Here, pathogenic bacteria release toxins and enzymes that trigger an inflammatory response in the gingival tissues.
So you can see it's the bacteria that cause that inflammation and cause that irritation of the gums. And the bacteria will also shed both in clumps and individual bacteria into the mouth, into the bloodstream, which can affect other parts of the body and cause chronic infectious diseases. So this is a paper by Paul Keyes and Thomas Rams in 2015. And this took a lot of work to get to this point, but essentially what it says is that the spirochetes and the clavicular leukocytes can act as a simple biomarker of a pathogenic biofilm. And it's able to be used diagnostically to assess the risk for periodontitis. The good thing about a paper like this is that the bacteria that we're actually looking at is this one here. It's actually the spirochete. So it's a very distinct shape and quite different from some of the other rods and circular cocci. And the spirochete, they typically have three major genera that cause disease. So the first one is treponema, and that's responsible for syphilis. It's responsible for periodontal disease and also early implant failure. We have Borrelia, which is responsible for Lyme disease. And we have Leptospira, which is responsible for leptospirosis. So the mouse plague that's out west, when they urinate on food and then people eat that, that's when people get sick and can die. And depending on who you read, certainly there seems to be a relationship with Alzheimer's and Parkinson's as well. It seems to be not only just spirochetes, but a number of other bacteria which can seriously cause illness. And if you think that syphilis is something that's not around anymore, this was just released by the Victorian government. They said that because of the lockdown, people should get their health checked because they don't know that they've got syphilis. So it's just still the third most contagious sexually transmitted infection in the world. And you can see the numbers out of the US, they saw 2020 as the highest number of babies born with syphilis since 1994. So when you have congenital syphilis, that is where it's transferred from the mother to the fetus, and that results in severe birth defects and terrible, terrible condition. So why we're able to use the spirochetes as a biomarker is because they're one of the late colonizers. So you have all of the normal bacteria which grow very, very rapidly. And it's only until some of these later colonizers, which like the conditions where there's a thick, sticky matrix, when there's a lot of other bacteria around, that you can actually get the spirochetes to replicate. And so, yes, very related to periodontitis. Problem is that you can't see them. And so these three pictures here are patients of ours. Which one of these have spirochetes? It's very, very hard to tell. What about after I've actually stained them with special dye which picks up and stains the biofilm? Well, everything that's blue is the stuff that's over a day old, and all the pink stuff is less than a day. And so you would think, oh, okay, that one on the left is a problem. When you look at it, the one on the left definitely has spirochetes. The one in the middle also has spirochetes, but the one on the right has got a healthy biofilm. So what does that mean? Well, we have devices like the airflow device, and this very quickly and comfortably cleans all the surfaces of the teeth. Right? So this is the best way that we can remove biofilm nowadays. It's a lot more comfortable than the ultrasonic tip that we use to scale around the mouth. And you can see there's different colors there. The blue is actually acidic, light blue is actually acidic bacteria. But unfortunately, even that is not enough. And that's because the bacteria are everywhere. As we said, it's not only on the hard surfaces of the teeth, but it's also on the tongue, it's on the palate, it's at the back of the throat. Anything that you put in the mouth, whether it be dentures or implants, they've all got bacteria on it. And any pockets that you have, especially around the teeth, they're going to become reservoirs for these bacteria. So in 2003, the WHO said that oral health and general health are very much related. And we know that conditions, for instance, like diabetes, it's a two-way street. Diabetes makes periodontal disease worse, periodontal disease makes diabetes worse. And you have very much a relationship with cardiovascular disease and stroke because of the inflammation that happens when the patients cough and they inhale the bacteria that are in the mouth. They can have lung conditions. We know that preterm low weight babies are born when there's a lot of bacteria in the mother. And we know that there's certain factors released from bacteria that also cause oral cancers. So this is a significant problem, not just for the mouth, but for the rest of the body. And it gets worse as the mouth gets worse. And that's all because, of course, as we said, the bacteria don't just stay in the mouth. Of course, we swallow, we take it into our guts, but as we get things like periodontal disease, we effectively have a break in the skin, and the bacteria will travel into the bloodstream. And when they test the clots, when they test the arteries, you can find the bacteria in those clots in the arteries. And so when you have a range of different bacteria, then you're going to start to have a range of different problems. And so scientists have been working out all the different kinds of bacteria that cause the different problems. And now with DNA sequencing, you can work that out quite effectively. So we have had the last 2 years of the most amazing education campaign telling us all about how inflammation is bad for us. So, it's no surprise that periodontal disease is one of those inflammatory conditions that it's not the bacteria alone, it is the inflammation that the body has. And it's the same in COVID. When we look at the relationship between periodontal disease and COVID. The term cytokine storm is now understood by the general public, which is quite amazing. So elevated levels of IL-6 interleukin-6, you have that in periodontal disease, and that increases the overall level of inflammation in the body. And so you have that very, it's a positive relationship in the sense that, you know, you have more of those biomarkers and you have more disease, right? So in the lower study, you can see there 3.5 times higher rate of ICU admission when there's periodontal disease, 4.5 times higher need for ventilation, and nearly 9 times higher rate of death. And of course, there's many things that govern the amount of information that you have in the body. We're talking diet, smoking, medications, genetics, but there's also diseases, you know, asthma, eczema, HIV, diabetes. These are all going to weaken the immune system. Then you have things like cancer treatments, organ transplants. You know, that's all going to affect the immune system as well. So, Dr. Bradley Bale, he's a physician in the US. He says that all good health starts with the mouth, right? And just look out for this guy on the left-hand side there. This is Bradley. Bradley Bale is in the middle of that picture. But together with Amy Deneen, they wrote the Beat the Heart Attack Gene. So some of you may know that book. And it's really all about finding the cause of inflammation in the body, because it's been known that since 2012 that it's inflammation that causes arterial disease. So where the dentists fit in is that we look after periodontal disease, we look after root canals, which is endodontic disease, so infections of the roots of the tooth, and we can look after obstructive sleep apnea as well. So by eliminating those conditions, we are allowing the patient to have better overall health. So how was I introduced to this? Well, you can see that the gentleman on the left, that's Thomas Larkin. He was in the photo with Bradley Bale. He's a professor out of the University of Kentucky. He's been using microscopy since the 1980s. And together with Sue Rislin, an Australian hygienist, they developed the Larkin protocol, which involved the use of the phase contrast microscope. And with the big screen TVs now, the patients can see instantly what is in their mouth. And, you know, hygienists, dentists and oral health therapists, they love this because all of a sudden the conversation shifts from, you know, what is periodontal disease and how do they get it, to how can I get rid of it? When do I need to see you? So this is what the biofilm looks like. This is in health. So you can see it's actually kind of boring. There's not much on the screen. There's hardly anything moving there. There's a few cells, but really not that much. So a few white blood cells, very few bacteria, certainly no spirochetes, and very little movement. Compare that with this. Okay, you can see that there's a few more things on the screen. When I started moving, you can see that there's those wiggly little things. Those are the spirochetes. The rest of the white blood cells, and you can see there's a lot of different types of cells that are there. And it's really all of that different type of bacteria, that colony, and the white blood cells indicative of inflammation. The spirochetes as an indicator that it's a comfortable environment for them to grow in, and lots of movement. So this is a 16-year-old, and nowadays we will disclose all our patients. So we'll put this dye into the patient's mouth, and very quickly we can talk to the patient about where they're not brushing very well. And you can see on that lower picture there's the bleeding. When you look at the the slide, you can see that there's a lot of those wiggly things that are moving on the screen. There's heaps of activity there. Lots of a mix of different rods and cocci. And that's a 16-year-old. Can you imagine what happens? So 16-year-olds not very well, they're well renowned for not brushing their teeth. They're teenagers, right? So as a teenager grows into an adult, they continue to have that dysbiotic biofilm. This is a patient that came to us with severe decay. You can see on that panoramic radiograph that there's a big hole in one of the teeth, and I took a picture and showed the patient. And she was like, okay, well, just fill it. But when I showed her the biofilm, she went, oh my goodness. And so she really understood that it's the bacteria that are causing the problem, and it's something that she needs to look after straight away. This is just a gentleman that has tooth sensitivity and had a bit of a toothache, right? And this is a patient that we had been seeing for years and years, very regular with his hygiene. Look at that. Look at how much everything is moving on the screen there. There's a huge amount of movement. And it's even hard to tell, but there's actually spirochetes there as well. It's so overwhelming, all of that movement, that you don't really see the spirochetes, but they're there as well. You can see the rods zooming around, and these vibrios and all these kind of gliding rods, all this pathogenic bacteria in his biofilm. This is a 12-year-old, and this 12-year-old came in and they had swollen tonsils and really, really bad breath. We showed him how he was not brushing so well, and the huge amount of spirochetes in his biofilm. In this case, we decided that he needs to have some antibiotics. So we gave him some antibiotics that reduced the swelling of the tonsils. He no longer has the bad breath. But we're going to have a look at him in another few months and retest him and see what happens there. Now, this is a patient that came to us and they had to have a lower molar taken out. The molar was flapping in the breeze. There's no way I could save the tooth. I took the tooth out and grafted it. And he came back to us and said, okay, I'm ready for the implant. So at that point, I had started using the microscope. So I said, let's have a look. And you can see just phenomenal, the amount of bacteria that were there. And this is the same patient. We looked on a different part of the slide, and you can see the spirochetes. And the spirochetes are in the star-shaped formation, which indicates very, very advanced spirochete infection. And there's lots and lots of white blood cells as well. Not something that any patient wants to see, believe me. And I have had patients just swear in the chair just about what they're seeing there. So this gentleman has caries, periodontal disease. You can see the breakdown on his teeth. In the upper right-hand side there, you can see the blue. All the blue indicates that that is highly acidic bacteria. His biofilm isn't quite as active as some of the others, but yeah, there are spirochetes there when you look, white blood cells. So certainly something that needs to be attended to. I had a mother tell me that seeing the worms on her son's teeth, is the only thing that motivated her son to actually brush his teeth. So I think if it can motivate a child to brush their teeth, then that's a good thing. So this is a young mother that came to us with with a lot of caries in her mouth. You see lots of white blood cells there. You can see everything is moving. This is probably one of the worst cases of spirochete infection that we've seen. And the issue is that she also has children with a high caries rate. And so, of course, these, the mothers kiss the children and they pass on these spirochetes to the children as well. So, it's within the whole family that you have these kind of problems. So let's see. Stopped. See if I can get to the next slide. So this is a nasal fungal infection, and the patient has come to us and she managed to get a nasal swab of herself, and she in the surgery, and she gave that to us, and we could see that there was a fungal infection, some sort of yeast in there. So it's a very, very quick way that we can identify something that's going on with the patient. So as a laser dentist, we often treat periodontal disease, and we do that with the laser. I sanitize these pictures so that this one didn't have any blood for you, but we would typically use the laser deep into the pockets, clean all of the diseased epithelium, clean the tooth surface so that the gums can reattach to the teeth. You can see that after 3 months, very, very nice result. They're nice and tight pockets. This is how the patient turned up to us after 3 months. We had a look and we saw a whole bunch of spirochetes. And then at 7 months, when she came for her next clean, we saw a huge amount of spirochetes. So unfortunately, as good as the laser does, and the fact that it actually helps remove that infection, we are still continuing to have that dysbiosis. Right? And this is what's going to set them up in the long run to fail if this isn't dealt with. You can see on the lower right hand side that she doesn't have much bleeding there, and there was no pocketing as I sort of checked around the mouth, but she still has all of the spirochetes. This next one is a video by my friend Kate Phillips. I think she's on the call.
Yep, there's that one there. It looks like that's, yep. Oh, yep, go back there. No, go, oh, there's that one there. That's another one there. And there's another top one. So this patient has been told she has a parasite in her stomach, and she has been reluctant to take the antibiotics because of the strength of the antibiotics. And I told her that if this isn't a sign to do so, then I'll be going it for chasey. So I'm hoping these two amoeba look like they're gonna join together, join forces. So I've told her that whatever that antibiotic is, she needs to take it, and she's coming back to see me. Yep, there's 3 very close together. She's coming back to see me in the next month ideally, so that we can get onto this from a biofilm perspective, because she also has, oh, there we go, she also has a lot of spirochetes as well. So this is the biggest case we've seen at Sri Dental.
I was just joking with her today that all the amoebas in Tasmania, because I've never seen an amoeba in any of my slides so far. So this is the voice of Professor Tom Larkin.
This is a trichomonad. Kind of looks like a small mouse. It is a protozoan, which is a one-celled animal, similar to an amoeba. never seen in a healthy mouth, always associated with pathogenic biofilm. And when this is present, regardless of how the mouth looks, this is a risk factor that is either beginning or in an advanced state.
So one of the other nasties that we get. Well, it all sounds like doom and gloom, but there is some light at the end of the tunnel. So this is one of the things that has been very successful for us. We've been using ozone. So ozone's been used for a long time. It's used in pretty much every industry that involves water. So ozone's a naturally occurring oxidant that is antibacterial, antiviral, antifungal. And the ozonated water will break down to just pure water after a number of hours. And so the food industry uses it, professional restaurants, professional cleaning companies, and healthcare, aged care, childcare, facilities. You've got sprays and so on. So these you can get as taps. You can get it as a central disinfectant unit, like what I've got in the dental surgery. And that's what we use as a preoperative rinse for our patients. We use it in the dental chair. We use it coming out of that airflow device. We've got it coming out of the triplex, out of the dental handpieces. But the really nice thing now is that we also, in the top right-hand corner, that guy there, that's an ozone tumbler, right? And that is something that we've been able to give to our patients to use to reduce the bacterial load in their mouth. So let's have a look. This is a gentleman that came to us, and he said to me, he said, "Oh, I had 3 stents put in. Do you need to know that?" Well, he told me that he went to the doctor because he was having a bit of chest pain, and they said, "You're having a heart attack. We need to get you to the hospital right away." And you can see the star shape again, spirochete formation with him. It's a very, very advanced state of infection. And on the right-hand side, after 3 months of rinsing with the ozonated water, there's pretty much no movement there of anything. None of those white blood cells. Very, very improved biofilm. If you look at it, you can actually see there are still some spirochetes, but it's so much better than it was before. This is a gentleman that was referred to us by a periodontist, and he was told that, yes, he was ready for his implant. So we tested it, and we found very, very high bacterial load, lots of spirochetes. We got him to do some rinsing at home, 2 months of rinsing at home, and you can see it's hardly anything on the screen there. Very, very boring slide, which is what indicates it's healthy. And this is a case of a young lady that came to us. She had an infection around a newly placed implant. We saw a lot of spirochetes in her biofilm, and after we used the guided biofilm therapy and laser therapy, and then she brushed with some tooth serum, it's pretty much complete change. So I think the thing to understand is that the oral biofilm needs to have a balance. You need to have that commensal bacteria. So even something like Dr. Hisham's tooth serum, which is a coconut oil based with xylitol and essential oils, that is very nourishing for the biofilm, and that is why something like that can be very helpful in managing that bacterial load that's in the mouth. And we also have the ability now to test the biofilm. We can take a spit sample, or we can put some paper points into the pockets, and we can have a look at anywhere from 5 to 10 sort of different types of bacteria. We can see which ones are overgrown, which ones are the likely ones to cause the problems, and then possibly treat them with antibiotics or whatever type of anti-infective solution that we decide to use. It can be peroxyl, can be hydrogen peroxide, maybe iodine. you know, those kind of things. But as long as we are managing the biofilm and reducing that biofilm, that's when we can have success. These companies are also able to test for some of the other cytokines, IL-6, IL-1, you know, and some of the other factors that put the patient at risk. So all of those inflammatory markers, they can measure those as well. And so when you start to see some of the problems that arise from this type of pathogenic biofilm, you can see why it's so important to have it managed properly. So everything from autoimmune conditions to malignancies, you know, they all seem to be bacterially based to some extent. And then what I would like to see is a better relationship between the doctors and the dentists. And so we now write reports to the physicians, and we'll give them a report saying, you know, this is what your patient is doing. They're currently at high risk. We're trying to manage their risk, and they, in this case, after 3 months of rinsing with the ozone, the risk is down to medium risk. So having already had the one heart attack, I think we certainly, he's certainly at higher risk of further heart attacks. So we want to be able to give him some hope, reduce the inflammation, certainly from our point of view. Anything that we can do to reduce that inflammation is going to be healthier for him. And, you know, I hope that we can have a good relationship with all of you guys, and work together so that we can, you know, get the best outcomes for our patients.